Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Today I'm joined by Chestnut CEO, Dr. Dave Sharar, who has been with Chestnut Health Systems for 35 years and has served as CEO since January of 2018. From 2000 to 2015, Dave was managing director of Chestnut Global Partners, where he's responsible for operations, strategic partnerships, and growth for a domestic and international workplace behavioral health/employee assistance firm with over 600 employer customers, 1 million covered employees, and 123 network provider partners in over 100 countries. And Dave joins me from his longtime headquarters in Bloomington, Illinois. Hey, Dave.
Hey, Charles, good to be with you.
It's good to be with you. 35 years. I think I've known you for about 20 of those, Dave.
That sounds about right, Charles. Yeah.
If you recall, our initial contact, you had reached out to engage me and my team at the time to write what we were calling EAP for Dummies. It was sort of a handbook, a history of um, different evaluation strategies and so forth. I don't know what ever became of that, but that was the first project, and I think an appropriate one for us to begin this long relationship on, Dave.
Yeah, with your credentials, Charles, in business development and human resource marketing and so forth, we were trying to educate purchasers on the value of what we did. And so you
Yes.
helped elevate, our status in that regard.
That was a fun period. I really enjoyed that. And it was kind of interesting from my personal perspective because prior to that, I had started my company, Backbone, as a technology business advisory marketing firm. First company that our first client was a company that put summary plan descriptions online. From there, we got involved with a wellness or work-life services provider, and they were also looking to move their program online. And through that, I think I came to Chestnut. So it was kind of an interesting, somewhat related, but kind of circuitous path because I never would have expected to have started a technology advisory firm and then, do the work for Chestnut, but it was a great project, and you guys had an amazing business model.
Well, and the other thing that you did for us, Charles, that was really important was we were very focused on differentiating ourselves by measuring outcomes, which wasn't being done in the field. And we just didn't want to put something in a journal somewhere that no one read. And you helped us get our studies out in a way that a busy HR executive could understand something and in a media form that they would read. So I think
Yeah,
those were the good old days.
they were the good old days. And in fact, it's kind of interesting you brought that up because I guess there is kind of a continuum. You mentioned the workplace outcomes suite. And that sort of is, in a way, a continuum of my work using tools. Sometimes they're technology tools to provide objective measures or to improve efficiencies in a demonstrative way. Anyway, so fast forward. Now we find ourselves where we are. And, I'm going to ask you what I've asked other guests I've had on this pod, which is what brought you to this work originally?
That takes me back a long time. In when I was a young person growing up in central Illinois, uh, in the 70s and 80s, we used to have people with mental illness and chronic addiction in long-term institutions in state hospitals. And I grew up in a town with a state hospital, and my mom would go there for holidays and take cookies, and we were allowed to socialize with the patients then. And so I'd go with her and tag along, and I'd be so curious and interested in what happened to these individuals. How did they end up here? What caused all of this? And I spent a lot of time asking them questions, and just trying to learn. And then I decided I wanted to work with people that had problems and issues and understand what was going on and how to turn that around. And then that led me into some vocational work where when these individuals were discharged and the state institutions closed down, they ended up in the community. We tried to figure out what can they do during the day. Can we create jobs? Can we create workshops? And how do we help them find employment and get a paycheck for the first time and feel meaning in what they do? So that led me kind of to the philosophy of the importance of the workplace.
Yeah, it's interesting. I've known you all these years. I've never asked that question. I never knew any of that. So glad we have this podcast. Um, so let me ask you, 35 years in the field, if you can boil down all that experience into one change that has been most significant or maybe unexpected in any preconceived ideas you had about this industry, about treatment, anything about the tools that you're now using that maybe have changed the face of your industry, what would you say? What would the one thing be?
I think there was a period, Charles, where our work may have been a bit marginalized by, funders and even some of the public not understanding it. There used to be a great deal of stigma and fear and hiding around having a mental illness or a substance use disorder. And what I've really seen is really in the past decade or so, a growing recognition in the value and importance of what we do, because these problems are worsening at some level, and now is not the time to not invest in them. And there's also a belief, and we have a lot of knowledge that what we do in some segments works, and actually people do improve. And yes, there's relapse and remission and all of that, but people can improve and they become productive members of the community again. Their families in better shape because of what we do. So I think that even in a political level, there's bipartisan support for mental health and substance use care that's really, been recognized now more than ever. So that's not necessarily an innovation, but it is a positive, movement over the past, 10 or 15 years.
Oh yeah, no, and obviously of a great importance. And I do want to get back to this notion of bipartisan support, but for another topic, which actually moves to what we really want to focus on today, and you teed it up very nicely, which is Medicaid. You talk about mental health services, EAP, long laboring under this stigma because people have a very narrow conception of mental health, root causes, all this stuff. And I think the same largely applies to Medicaid. People have very preconceived ideas, narrow views of how that money is allocated and to whom. So why don't we begin by talking, and we've kind of come at this on the pod and actually on the Substack newsletter that we do from various angles, but I'd like to get your perspective on that particular issue. I mean, how ought people look at Medicaid?
Well, it's the largest funder in the country of mental health and substance use services, and it is the primary funding mechanism for not-for-profit community mental health and substance use centers, behavioral health agencies around the country. And in every state here in Illinois, there's around 3.5 to 4 million individuals covered by Medicaid that rely on Medicaid as their lifeline, not just for mental health substance use care, but also for primary medical care and specialty care. And so a lot of people, I don't think they appreciate the depth and importance of access to care, that is funded by Medicaid. There's a lot of individuals, we might call them working poor, who do work, who cannot afford to buy insurance on the exchange. Their employer, they might work part-time or full-time. Their employer doesn't provide an employer-sponsored benefit, and they don't make enough money, or they don't make enough money. They qualify for Medicaid, and so that is how they get, their health care.
I know a number of your programs, Lighthouse, Chestnut, are funded at least partially by Medicaid, You guys are doing amazing work in the community, with the community, various stakeholders, law enforcement, volunteers, small business, and so forth. And again, these are the things that actually tell the stories. They show how Medicaid monies are being productively and effectively used. So maybe you can talk about some of the projects, some of the programs that Lighthouse and Chestnut is doing, just to give people a good idea.
Yeah, so our focus here at Chestnut, Charles, we're somewhat unique here because even though we're a traditional community behavioral health provider, we had a recognition that many of our patients had unaddressed primary medical care needs. About 15 years ago, we decided to take one of our addiction treatment units and open up a small exam room where a part-time doc came in a couple times a week and started doing physicals and sent off lab work. And many patients discovered that they had a cardiovascular problem. They were pre-diabetic. They
And
had
where would these be deployed?
they would be deployed inside our behavioral health treatment center. So we were taking what was only at this time an addiction treatment center and embedding primary medical care there with a primary care doc. So this grew over time, and so we eventually became what is known as a federally qualified health center, which is a federal designation for people who are medically underserved to get better access to care. And we get an enhanced Medicaid rate to make sure that access is possible because, again, bipartisan support that many of these individuals would use the emergency department or an urgent care as their primary place for medical care rather than finding a medical home. And that's the most expensive, inefficient, model. A lot of our emergency departments, as good a job as they do, are crowded. Some of them even have boarding with people with serious mental illness where they can't find a hospital bed and they get boarded. And so this is the most expensive place to do that in. So what we do is deflect from that. And so the idea is for our Medicaid covered patients to use outpatient ambulatory community-based centers for mental health, substance use, and primary care. But we want our clinical staff to operate as a team, and not be in a silo. You go here for mental health, you go here for substance abuse, you go over here for your primary medical care. They don't talk to each other. They don't have the same electronic medical record. Many of the patients don't make it to the referral. So the idea is there's no wrong door. You come into our door, we're going to figure out. And by the way, many of our patients, well over half of our patients, have multiple conditions. They don't just come in with major depression or alcohol use disorder or diabetes. They come in with all three.
Right. Which goes to the idea of integrated health.
Exactly. And that's the whole concept of integration is you have a team that works together with the patient and talks to each other about their care. All of us have had experiences in medical care where we go to a provider and the information doesn't get passed on to referral, and we tell our stories over and over again. And the idea is to prevent that. So we work very hard at integrating care and making sure that our staff communicate with each other. So in one of our, in a lot of our agencies, we have a pharmacy on site. We have a lab on site. We have behavioral health clinicians and primary care docs and nurse practitioners. And even in one location, a dentist and dental hygienist that all are part of a team. So the pharmacist, the dentist, the doc, the behavioral health counselor, they talk to each other about who's coming in today and what are we going to do with this patient.
Yeah, I shudder to think with all the talk about Medicaid funding being on the chopping block, the implications for all these programs and these delicate ecosystems. And if it's suspended or dismantled, they're hard to put back together, I'm assuming.
Absolutely. And there also you asked about, misperceptions. One misperception is that Medicaid is wasteful spending. Granted, we all want efficiencies, and if you search hard enough, you'll find waste in any system to be corrected. But in reality, what happens is if we cut this spending and cut these benefits, that cost will get shifted. It will not save money. It will cost money in another place. So I just gave the emergency room example. Another example is law enforcement and incarceration. And, when you have an individual who has a substance use disorder, they end up in the criminal justice system. They end up in episodes of domestic violence. There's more arrests. There's more jail time. There's more judges. It's a burden on our criminal justice system. So we will see those costs get shifted, and
Right.
and so that we know that could easily happen.
Yeah, it seems like if we move in that direction, it's going to be, to put it charitably, a very big experiment. And one person's waste could simply be what they don't like. And the tax code has often been referred to as sort of an implicit moral code. I mean, because one person's waste is another person's priority. And if you don't like something, it doesn't necessarily mean it's wasteful.
Right.
Um,
And we also need to think, Charles, we tend to focus on urban areas, but Medicaid is really important in rural and small towns.
yes.
And for many of those individuals, and many of them did vote Republican, and they rely on Medicaid, and they're in small towns, and those small town hospitals will not make it if this is cut.
Yeah.
It's gonna affect everybody. That's going to affect people who are commercially insured, people who are on Medicare when that hospital closes.
Right. And I know that's where particularly Lighthouse and Chestnut shine as far as lowering barriers to access, bringing these services where people live, going out in the hinterlands, going out to these rural areas. It's a big challenge. And again, some of this funding gets cut and that goes away. How do you sort of reconstitute that? It's going to be hard because eventually it's going to have to be reconstituted when people see the wreckage, when people see the ruined lives, and you have Republicans in whose districts these people live.
Right. We reopened one of our centers in Metro East St. Louis, Charles, not too long ago. We had during the pandemic, we had to close one of our buildings, but we reopened it as an integrated care center. And we decided to offer medication-assisted treatment for opioid use there. And there's a lot of no-shows for that kind of thing. Someone calls for an appointment and you make it a couple of days out and they no-show on you. So we just decided we're taking walk-ins. And on the first day, we had 33 individuals walk in for medication-assisted treatment for opioid use. So again, this is a bipartisan issue dealing with the opioid crisis. And why would you want to cut that off, right? I mean, that doesn't make any sense to not encourage and allow, that sort of treatment access, which, by the way, most were Medicaid covered.
Yeah, well, politicians certainly are not shy about shouting from the rooftops about the scourge of opioids and all this stuff. And when it comes down to it, real proven solutions, because it doesn't align with what they're supposed to be aligned with, it becomes verboten. Speaking of all this, there's also been talk of attaching a work requirement to Medicaid. What are your thoughts about that?
Yeah, that's a good question. Conceptually, I think it's been exaggerated, the number of able-bodied individuals on Medicaid who aren't working. The statistics is around 2/3 of Medicaid covered have some work, even if it's part-time. But conceptually, I believe in the value of work, but there are significant complications and analysis where this needs to be thought through. It was tried, I believe, even during the Clinton administration in the state of Arkansas, which it didn't work very well. A lot of people ended up getting disenrolled from Medicaid because they couldn't provide proof that they were working. And then you had individuals who were trying to find a job, and so all of a sudden providers are running around before they can get paid, trying to verify someone's work status and how many hours they worked. Did they work 80 hours in the past month? Prove it. And getting that kind of documentation is expensive. And our case managers already have a lot to do. And now we're going to ask them to prove someone's work status. our clients do not come in with a pay stub, to prove that they're working. So how is this going to be monitored? And my concern is that conceptually it's a good idea, but it won't be administered properly. So what'll end up happening is a lot of people get dropped from coverage.
As the CEO of Chestnut, given what many providers in the industry are looking at, grappling with, I have to imagine there's a lot of anxiety, a lot of uncertainty, and probably feelings that go even deeper than that. What would you say to those providers and people in the field providing services who are concerned about where this is all heading?
Yeah, I'm seeing signs, Charles, that there is recognition that originally the House, put $888 billion in savings over 10 years, and there was no way they could achieve that savings without drastically cutting Medicaid. But I've seen some movement and recognition about the importance of not doing that. Now, we want to make sure that those individuals who were covered under the expansion that occurred don't get disenrolled, because the traditional enrollees tend to be disabled, or elderly or poor. And but in terms of your question, I'm having some hope that this isn't just about cutting spending, and they're cutting it in the wrong place if they do this, because it will end up costing more. So I think that in the end, we're going to see an outcome where there'll be some changes in the Medicaid program, but it'll hopefully be done carefully, and, to use a famous quote now, with a scalpel and not a chainsaw. We've seen quite a bit of this chainsaw metaphor, which doesn't have a lot of thoughtful or systematic approach. So we're all about finding efficiencies, but providers like Chestnut and many of my colleagues, we're already running lean. We already have a workforce shortage problem in the face of a worsening mental health and substance use crisis. So it just doesn't make sense. And so I think I'm seeing signs of some recognition, on both sides of the aisle, that this is important to keep these programs intact. And I get trying to save money, but this is not the way to do it. And
No, I think what would give me encouragement is that this is not an abstract issue, nor is this about a quote unquote out group, like much of what's going on with the immigration debate is. Ultimately, we're going to be people in our communities, people we can identify with, who are going to be in a very bad way because of these cuts. You have heard Josh Hawley and others, whose conservative credentials are for the most part beyond reproach, depending on who you're talking to on any given day. So, I just don't think this is going to be a cakewalk. I think this is going to be ultimately a very difficult issue.
And Senator Hawley in Missouri in particular has been pretty outspoken that these are his constituents.
Right.
People who support him and his agenda, from Missouri. And so removing this benefit could have catastrophic consequences. And then where do people get their health care? What do they do when they get sick? What do these people do that have cancer treatment?
Yes. No, yeah, no, it's easy to see some gut-wrenching stories that make people rethink this. So if anything gives me hope.
And then you think about how many millions of people in this country that worked hard, that were middle class, that saved money for their retirement in a rainy day, got really sick, ended up in a nursing home, spent their money down fast, ended up on Medicaid. A lot, right? That's just not who we are as a country. It's not compassionate.
Well, I think those are very good words to end this conversation on, Dave. I really do appreciate you pulling away from your day-to-day CEO chores to speak with me today.
Oh, thank you, Charles. And I will close with, these podcasts are great. The interviews you've done with our research staff, disseminating that knowledge, and plus the interviews with people outside of Chestnut that have a lot to say, smarter than me on this, what's going on in the field. So I know that the listeners will be anxious to hear from some of those folks as well.
Oh, yeah, no, for sure. Everybody who's come on has brought their A game, so they made us all look good. So, yes, indeed. Anyway, Dave, thanks so much. I do appreciate it. Today I spoke with Dr. Dave Sharar, CEO of Chestnut Health Systems. He's been with Chestnut Health Systems for 35 years and has served as CEO since January of 2018. He joined me today from Chestnut HQ in Bloomington, Illinois. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.